In this lecture, we will discuss first-degree AV block, including what it is, potential causes, its clinical significance, and how it would appear on the EKG. First-degree AV block is a minor conduction defect that results in a partial block at or below the AV node. So if you look here, we have this is our sinus node, okay? Then we have our internodal pathways, and this here is our AV node, okay? Then we go through our His bundle, our right and left bundle branches, and the fascicles, and so forth. So what we're saying here is that we have a partial block, all right, at or below the AV node, okay? So this is a partial block, a minor conduction defect that we have going on there. Okay, so as a result of this partial block, the PR interval, which represents most of AV nodal conduction, will be constantly prolonged. A wave will always proceed, a P wave will always precede that QRS complex because we have atrial activation and we're still transmitting to the ventricles. Okay, the only issue here is that there's a delay in getting to the ventricles. Okay, so we're still having, imagine our sinus node fires. Okay, we get to our AV node and there's some delay in this region. Okay, but eventually we still get down to the ventricles. So we still have our P wave and we still have our QRS complex representing ventricular depolarization. Okay, the only issue is that we have that prolongation at the AV node. So if you look here, here's our P wave, this is our QRS complex, okay, another P wave, QRS, and notice that we have our PR interval. Remember our PR interval? This is our P wave, this is our QRS complex, and this is our T wave. The PR interval represents from the beginning of our P wave to the beginning of our QRS complex. Normally that should be between 120 and 200 milliseconds, which is 3 to 5 small boxes. Okay, so in this case, notice where it's starting from this point here until here. All right, it's well beyond at least one small box beyond one of those thick lines. Remember, one of the thick lines from one thick line to the other represents 200 milliseconds, so you can use that as your cutoff. And here we can clearly see that it is prolonged throughout all of these. Okay, and one thing to note is that it's constantly prolonged. Okay, it's always the same throughout. So you have a prolonged PR interval that is constant with each beat. So let's go through some of the causes that we have here. So one thing to note is this could be a normal variant. Okay, some patients can just simply have this. It could be a result of an increase in vagal tone, such as with athletes, or vagal stimulation. It can be a result of inferior myocardial infarction. Okay, mitral valve surgery can be a cause, myocarditis, especially Lyme disease. Okay, and we'll see that Lyme disease can actually cause a number of degrees, even up to complete or third degree AV block. Hyperkalemia can be a cause. AV nodal blocking agents such as beta blockers, calcium channel blockers, digoxin, and amiodarone are also potential causes of first degree AV block. Now, in terms of its clinical significance, this is not a cause of hemodynamic instability. So generally, there's no specific treatment that we typically require for first degree AV block. Okay, so we don't need any pacemaker. Patients tend to be okay. If it's a result of Lyme disease, make sure you treat the Lyme disease and so forth. Now, in terms of the regularity, again, this is a regular rhythm. Everything is still appearing normally. So what we look here is that if we look at our intervals, we'll use our R to R interval. From here, one R wave to the next. All these R to R intervals will be constantly the same and regular throughout. Okay, so they're all the same duration if you were to measure them out. So we call that a regular rhythm. The rate depends on whatever the underlying rhythm is, okay? So whatever, if we're coming from the sinus node, that may set the rate. In terms of the P waves, we said they're present. We saw all our P waves here, and they'll have the same morphology as long as they're coming from the same area, okay? And if they're coming from the same focus, such as the sinus node, the axis will also be the same. We also mentioned there's a P wave to QRS ratio will be 1 to 1. We always see one P wave in one QRS complex, okay? No dropped beats that we will see in these, okay? So one P wave, and it's always preceding that QRS complex, but in this case, it's just taking longer to see that. Now again, the main issue here is with our PR interval. It's constantly prolonged, and it's beyond that normal 120 to 200 milliseconds, okay? So greater than 200 milliseconds. If it's greater than 300 milliseconds, we call that marked first degree AV block, okay? So the main thing here is just know if it's beyond that 200 milliseconds, you're dealing with a first degree AV block. Remember, it's constant, okay? Constantly prolonged PR interval. Now the QRS interval will be normal. So our QRS complexes, okay, our intervals from the beginning of our QRS complex to the end of it, it'll be normal, no issue there, and there will be no grouping. Okay, so pretty much we have something that fires in the atria, gets to, let's just erase some of this here, so again, firing from the atria. Let's use our sinus node. We get to the AV node and there's some delay here, but eventually we get through. Okay, so everything down here is still normal and we have a normal QRS interval. Okay. So the main thing here to realize is that this is a minor AV conduction defect. It's a partial block at or below the AV node. Okay, you're always having a P wave preceding the QRS complex, but you have this fixed PR interval. Okay, that's prolonged. So constantly prolonged PR interval is the main thing you should be looking for here. Well, that's the end of this lecture. We discussed first-degree AV block, including what it is, potential causes, its clinical significance, and how it would appear on the EKG. I hope you learned something.